Terrific. Well, thank you everybody for joining us for another one of our wonderful MAG educational seminars. Today we have Ocular Emergencies for Paramedics by the esteemed Dr. Thomas Walker, ophthalmologist. Now, Dr. Walker has been working with eyes for longer than you and I have had hot breakfasts. He is an absolutely amazing man, and if you Google his achievements and his esteemed career, they are incredibly impressive. Including serving as an elected member of the medical board in the ACT, as well as travelling with and working with the late Dr. Fred Hollows in remote and Indigenous communities for life-saving eye surgeries or sight-saving eye surgeries. He's also just a lovely guy to deal with, and this subject matter here is very interesting and pertinent to a lot of the matters that we see coming towards us. So may I ask if you retain your microphone on mute so that no sound from your home or workplace interrupts the quality of the recording. But at the end of the session, there will be an opportunity for you to ask questions if you have them. You can also put your questions up in the chat if you would prefer. So without further ado, over to you. Thank you so much, Dr. Walker.
Thanks, Michelle. This presentation is for the first responders, although it says paramedics. But remember, if there's a problem, then you're going to be on the spot. And I hope that this presentation gives you some background for something which, of course, may never happen to you.
All right.
Ooh. We want to identify the symptoms and signs that can indicate threat to life or sight. Now, life is important because that may be an associated problem. We want to cover the initial first aid, look for urgent referral problems, and please and get advice from the history from whoever was nearby. So we'll cover trauma, burns, vision disturbances, red eye and lacerations to the globe and the lid. Just a review of a bit of anatomy, cornea, iris, pupil, of course, is the whole, lens, vitreous, retina, and the macula is where we have a concentration of cones for most acute vision. Next. Now, exactly is emphasized there because
Sorry about that.
No, sorry, that's fine. What the witnesses say may not be accurate, so be very careful to get a very good history from a good observer. If the patient is able to tell you, is there any previous problem? Do they wear contact lenses? Do they have any other previous poor vision? Now, to open the lid, be careful that you press on the orbital margin and not on the globe. Here are the fingers on the bone, not on the eye. To evert the lid, you pull the lashes out and press on the top of the tarsal plate. Well, I've got a cotton bud here, but anything straight, even the end of a ballpoint pencil, pull the lid out and up, and then swing the lid over, and you'll see the inside of the tarsal plate of the upper lid. Thank you. Oh, something's happened here. I'm sorry. I thought I'd move that. Let's see if I can There we are. If they have a contact lens, here is the lens between, soft lens between two fingers, squeezed carefully and lifting without pressure on the globe. Slide the lens off the cornea onto the conjunctiva and then pick it off. A rigid contact lens may be very hard to see, but you'll see a small edge of reflection, which will be less than the diameter of the cornea. And again, the patient, if able, may be the best person to remove it. Otherwise, slide it off onto the conjunctiva. But if you can't remove it completely, at least it'll be safe on the conjunctiva until somebody else can do it properly. Fluorescein is a dye which you're probably familiar with because it fluoresces, so that the incident light and the reflected light are different. And here you have a piece of fluorescein strip, putting it into the tear lake in the lower conjunctiva. And here is an ulcer stained with cornea. The arrow shows you. Fluorescein stains collagen, it does not stain intact epithelium. So going on to trauma, blood penetrating injury, chemical, thermal, and tear gas. Blowout fractures. Here the eye on the right does not elevate, and that's because the inferior rectus and inferior oblique muscles on the floor of the orbit, and also the adjacent connective tissue are caught in a crack in the lower orbital floor. When you have an injury such as a fist, tennis ball, squash ball, that occludes the orbital rim completely, the pressure inside goes up. The globe is not ruptured because the globe has all the pressure in on it, and the thinnest bone will then break. It is usually the orbital floor near the infraorbital nerve, and sometimes the medial floor going into the ethmoid sinus. Here you see a tennis ball, occluding it, and a squash ball at just the right size to occlude. And it is a very important diagnosis to make, because the long-term problem is optic atrophy. Thank you. Here you can see the iris torn away from its root, giving an irregular pupil, which doesn't relax, so it doesn't contract with light. The good red reflection means that the vitreous is clear, which is a good sign. This may or may not need surgical repair, but glaucoma is a long-term possibility and needs continuous observation. here are two little things that may distract you from what is really happening. Here is pterygium, which is nearly always nasal and ultraviolet light induced. And here and there, arcus senilis, a grey ring, which is a fatty degeneration of the collagen of the cornea and is of no visual significance. Don't let that distract you. So chemical burns are very important, very difficult. Alkalis liquefy protein and penetrate through the cornea into the anterior chamber very quickly, like in about 10 seconds in some cases. They are not as painful as acids because they kill the nerve endings very quickly. Acids, on the other hand, coagulate the protein of the epithelium and often delay or prevent further acid penetration. Testing for pH you wouldn't do, of course, on the site, but if the patient is in A&E and you're testing for the pH to decide whether there was an acid or an alkali, make sure we do both eyes. Remember that local anesthetics are going to be slightly acid. If possible, what is the strength of the solution and what was the nature of the chemical? This isn't always possible to find out, of course. Lime, builder's lime is a very common one, and it comes as a powder, which can be splashed in the eye. And it's very important then to put local anesthetic in the eye, irrigate copiously, and turn the lid inside out to make sure that there are no powder left, because this will have to be removed mechanically. Was there any other injury? Here's a mild chemical burn. It'll probably cause some scarring in the conjunctiva, and it shouldn't be too bad if properly managed. This, on the other hand, is going to be a problem. There's an ulcer here at the edge. There's been a subconjunctival hemorrhage, and the corneal epithelium is missing. As you can see, the reflection of light is all irregular, and the cornea has gone opaque. That could be a long-term problem. And here is what could be a disaster. All the epithelium is gone, cornea is opaque, and gross damage also to the conjunctiva. So that will have scarring as well. And that may require not only a corneal graft in the long term, but also conjunctival. So the secret of any chemical burn is copious long-term irrigation, even with the garden hose, if that's the appropriate thing nearby. Check for granules of powder under the upper lid, and then oral analgesia is indicated, even though corneal nerves may be damaged by alkalis. And if you have it available, antibiotic drops, otherwise pad and refer immediately. The cornea here is opaque and the conjunctiva is damaged. Capsicum spray is the basis of all tear gas sprays that are used for crowd control, and they're all oil-based. So washing the face will be useful to stop the scarring on the skin. If it's available, nose dish shampoo, but that's probably not what you'll have in your kit. And look for any other chemical damage, and also perhaps foreign bodies, as you would see in crowd eruptions. Do not use skin cream or anything, because they will absorb the capsicum and prolong the effects. So leave everything open to evaporate. Pain relief needs to be oral, and remember that inhaled spray may also cause asthma. Thermal burns are uncommon, but they need quick referral. And remember, as we said before, the observer's finger is pressing on the bone and not on the globe. Superglue, that's a problem, isn't it? The idea is to get water underneath the lids. Sometimes you'll find that the upper and lower lashes are fused together, so that's useful. You can pull them out and get water underneath the lids to wash out, but send it off to the ophthalmologist straight away for removal and treatment of the inevitable corneal illusion. Permanent visual loss is possible. Now here's a good example of unprotected workmen, and again the history of what was actually happening is important. The foreign body comes from the hammer because that's the tempered instrument, and it is a small high-speed particle penetrating with often very little pain, as opposed to burns and lacerations. And therefore, if the history is appropriate, X-ray on suspicion, because of missed foreign body will cause significant long-term problem, as all metals will corrode and cause fibrosis. The same as you will remember, iron in the liver causes fibrosis. Here's an intraocular foreign body in the anterior chamber, and you can see there's been very little disturbance of the surface of the cornea. There's the penetrating site. That, of course, needs surgical removal ASAP. On suspicion, X-ray. Gently assess in case it's a penetration, which you may make worse by pressing on it, and you can see how tiny that foreign body is, but it's got to come out. If there's a possibility on the X-ray that you think there's gas, then don't send them by air. This, unfortunately, was a foreign body that was missed, and you can see the terrible foreign body there. You need to have a good care and not press on the eye. Gently separate the engines and ask the patient to move the eye so you can get a good view. Straight off to emergency. If you happen to have any fluorescein, this test is very simple when you're not sure. Stain the whole of the conjunctiva with fluorescein, and here there's been a penetration, aqueous is leaking out and washing the cornea away, washing the fluorescein away. So that's a foreign body or penetration at least, and needs urgent referral. So don't forget tetanus prophylaxis as well as local antibiotics. Cover the eye with a shield. Help them to sit upright. Don't try and remove this foreign body because that will only collapse the globe. Don't let them have a drink, and make sure that you send a note with them if you've given analgesia. Open glow, well, that's a real problem, isn't it? Here's the corneal laceration. The iris is right up against the inside of the cornea. If you're going to cover it, put on a shield first, but do not put anything that's going to press on the eye. Help the patient to sit up so that they don't increase their central venous pressure and increase the intraocular pressure, and off to emergency. And this is what the corneal scar looked like after that eye was repaired. And as you can see, it's pretty much in the visual axis of corneal graft. It would be indicated when the eye had been quiet for at least 6 months. Superficial foreign bodies are relatively easy to remove with a foreign body under local anaesthetic. On the other hand, if it had been a metal foreign body and there are rostering remains, then be careful not to try to remove it, particularly when it's within the pupil area, because you then may be sued for visual loss. Send it off to the experts to have it removed. Well, this is great, isn't it? Blunt eye injuries with champagne were much more common years ago when they had plastic so-called corks, and the cork, if you shook the bottle, could easily reach 20 meters. Octopus straps, when you on your car, the strap will no doubt just come straight off if the hook releases and you're right in the eye. They also cause abrasions, hyphema, and if there is no penetration, they can still get late glaucoma, retinal detachment, retinal bleeding and hemorrhage and scarring. Be careful with the celebrations. Here's blood in the anterior chamber. Here is a clot. And remember that when you first see it, you may not realize there's been bleeding because the hyphema has a horizontal top because the patient has been standing up and the blood settles down. Here's a case where there are two injuries. Here's the clot, and here's this corneal abrasion stained with fluorescein, both of which need treatment. Traumatic iritis is not the sort of thing that a non-ophthalmologist would think about, But you've got a red eye, a hazy cornea, and an irregular pupil. And the irregular pupil may point to a possible area of penetration, but certainly that's going to be the area where the maximum injury occurred. Again, referred. Cataract, grey opaque. This case is traumatic because here is iris stuck to the anterior capsule, and also a bit of pigments also sitting on the anterior capsule, which was where that iris was stuck before the pupil was dilated therapeutically. Now, it's important that you don't forget that senile cataract will look the same, so the history is important. If you think that there's been a blood eye injuries, look for hypema, double vision, reduced vision, inflammation, and remember that a black eye, particularly bilateral, may be a fractured base of skull. Blood coming from behind through the orbit into the conjunctiva. Loss of vision, and this is all history. Loss of vision, sudden or gradual. Glare, do they have double vision, or did they have it before, of course? Do they have migraine? And if have any of these, then prompt, not necessarily urgent referral is indicated. This is what a retinal attachment looks like. When you look through the pupil, it's grey instead of red. And here is a tear in the retina caused by traction from scar in the vitreous, pulling the retina off where it was there. You won't see that, but I thought I'd put it in to give you the general impression of what's happening. Recent double vision always requires prompt referral. Look for local causes and central causes. Here is a man who, looking straight ahead, his eyes are straight. He then tries to look to the left, and the right medial rectus doesn't work. This requires prompt, but not necessarily urgent, referral, unless, of course, it's due to trauma. Third nerve palsies are very important. They are never something to be passed off. They are nearly always pathological, and a common one is aneurysm of the posterior communicating artery, as seen here, pressing on the third nerve as it goes through the back of the orbit. There's the chiasm, there's the third nerve, and here's the orbit, internal carotid. This is different to the man we saw with the fixed nerve, with the sixth nerve palsy. Here we have ptosis, probably a small pupil, and an eye which will not adduct, elevate. It is permanently abducted. Sixth nerve palsies are relatively common in older people, as well as sometimes congenital. Here's a little child who is trying to look to the right, and here's overaction of the medial rectus on the other side. Lateral rectus doesn't move, innervation overacts this. Here's a an older man with the same problem, but less obvious. Here he can look to the left, here he cannot look to the right. Fourth nerve palsies are uncommon, may be congenital, but there will be always a height difference. And make sure that you keep both lids open if necessary to see what the ocular movements are doing. Trying to look to the left and the superior oblique overacts because the inferior oblique overacts because the superior oblique isn't working. This is a typical corneal ulcer due to herpes simplex. You may rarely see it also in herpes zoster, but that'll be painful and requires prompt treatment orally with valcyclovir or similar if it's within the first 48 hours. This is bacterial, and there's opaque cornea with pus in the cornea, and you can see it's swollen because there's the ring reflection of the flash, which should of course be circular. Postoperatively, there will be a history, and here is pus inside the eye, unfortunately. That requires prompt removal and intraocular antibiotics. Fungus. Yeah, it's not fun, Gus. Here is the benign looking corneal opacity, which not necessarily accompanied by a red eye. It's slow, it's relatively painless, and takes a long, long time to treat. Angle closure glaucoma is more common in Asians, and the visual outcome is less than in Occidentals. People who are long-sighted have a shorter globe and therefore often a shallow anterior chamber. Here you see, with the light shining from the right, casts a shadow on the nasal side because the iris is convex and closer to the cornea. The pupil is irregular and does not react to light. This is a slit lamp view. There's the light from the slit lamp very close to the cornea. This is what's happened. The iris and lens are closer to the cornea as the anterior chamber angle rather gets occluded, like here. Pressure from the secretion in the ciliary body presses the iris closer to the cornea, and the iris doesn't work and therefore doesn't react. Acute narrow angle glaucoma requires urgent referral because the patient will have pain and loss of vision. Here is an iridotomy done by laser. Here is anterior chamber opacity called Glockenflecken, which will cause visual loss. Here is pupil that doesn't work, and here is the potential optic atrophy. So the duration of the pressure elevation is very important. The longer it's occluded, the worse. And just to show you something that you will not have seen is looking at the angle between the iris and the cornea with a mirror. There's almost no gap there. You can see it's all closed off. If that lasts for too long, then you may have scarring here and intractable glaucoma, which will need surgery. In your surgery, just remember that the ophthalmoscope has other uses, such as red reflections, eye movements, cobalt blue filter for corneal ulcers, and a red sleeve for bleeding in the retina, because the blood will look black because it's all red. Use your right eye for the patient's right eye. Better done when both of you are standing up rather than you breaking your back, bending over. A Morgan lens is what is used in casualty. It's a large scleral contact lens with irrigation, allows hands-free irrigation from a intravenous bottle, and some ambulance will have those on hand. It requires local anaesthetic. It may abrade the cornea and must not, repeat, must not be used if you suspect penetration. Look. Well, thank you all for attending. Happy to talk any questions you have. Thanks.
Thank you
Shirley
so
can
much,
turn that off.
Dr. Walker. That was fascinating. May I just say, I don't know if I speak on behalf of everyone else, but certainly turned me off my lunch. But it also made me realise just how vulnerable eyes are. And the question popped into my head, and that is, within your specialty, are you noticing more people presenting with eye injuries as the result of things that people are doing now, like fake eyelashes, eyelash implants, tinted contact lenses, and those kinds of things?
Yes, cosmetic activities around the eye are going to be an increasing problem. Tinted contact lenses should not be done online. Do not order your plain contact lens online, because it really needs to be fitted properly by an optometrist or an ophthalmologist to make sure that you do not finish up with corneal ulcers and corneal scarring. Yes, Michelle, that is going to be more of a problem as time goes on.
I've seen reports of some dreadful infections to the surrounding tissue of the eye as a result of eyelash implants.
Yes. Stick them on.
Yeah, or just, have your own eyes. But yeah. Okay, the other question I wanted to ask is, I noticed this, just anyone who goes into a pharmacy these days will notice an absolute array of products for use on the eye, including baby eye wipes that have now come out, and a plethora of dry eye solutions, and then liquid drops for red eyes, for sore eyes, for whatever else. What's your take on those as with your experience?
Most of the eye drops are safe. There was a big problem in Adelaide last century, which caused intraocular infections because they were prepared in the hospital dispensary. And since then, now there are very strict regulations about sterility for preparation of eye drops. There was, unfortunately, last month, a epidemic in America of unsterile eye drops, commercially prepared, and there was an eye loss from that. But interestingly, the same brand of eye drop in India and Europe did not have any problems. So yes, dry eye drops are usually pretty safe. Better you get a diagnosis because there are problems with the dry eye, which might be lack of tears, lack of meibomian secretions, the oil that stops the tears evaporating, or combinations of both, or rarely tumours of the lacrimal gland, which will cause a reduction in tears.
Right. Does anyone else have any questions for Dr. Walker? You can unmute your microphone and speak up if you do. No, that's good. I'm going to say that's usually because you've actually, oh, we've got somebody, Sue?
Oh, no, I haven't got a question, but I just wanted to say your questions were great, and to thank Dr. Walker because it was very informative and I really appreciated it.
Terrific.
Thank you. It's not kind of you to say so.
Well, look, we'll wrap up now then. And now the slides will come out to you, beg your pardon, in the next couple of days. And of course, this will be available on our YouTube channel, along with all of our other educational seminars. I urge you to watch them and learn from them because they're a really terrific resource. On behalf of MAG, Dr. Walker, I thank you so very much for your time today for what has been a very informative seminar. And everybody, thank you so much. Have a great rest of the day.
Michelle?
Yes.
I think, if you don't mind, before you